Okay, so it's my pleasure to introduce Dr. Dale Lee. As I mentioned, I'm not going to do a long introduction. He's at Children's Hospital, and the one thing I'll say is, I don't know if Dale remembers this. When he came out to interview, I don't know why Ghassan asked me to interview him because he works at Children's. And then they set up like some 7 a.m. breakfast, which I'm not a morning person, so you guys should be grateful I'm here and awake. And so we went to breakfast, and I never remember, first time you meet someone, right, you're making chit chat, and we're sitting outdoors. I don't know why, but we are. I got stung by a bee. You couldn't make this stuff up. So Dale, being the nicest guy in the world, is like, oh my goodness, right? So he goes, hold on. Takes out a credit card. I was like, what are you doing with that? And he scrapes the stinger. Do you remember this? You scrape the stinger on at lunch, and the wait staff was like, what is going on over there? So he saved my life, because I'm not allergic to bees. But that's literally the first memory I have of Dale. I was like, wow, he took the bee sting out. But Dale, what I will give him credit for, because Dale and Ghassan know I'm kind of on the opposite end of the spectrum. Again, I'm an adult gastroenterologist, they're pediatrics. Our patients come in and I get very, not frustrated, but I'm like, diet, we have not owned this. And what I will give Children's credit for is they said, you know what, patients are gonna do this anyway, right? So they're gonna do it. They don't listen to us, they're, okay, you wanna do it. So they've decided to own this and say, why don't we work with the patient? So they're smarter than us, right? We just gonna go, I don't know, do what you want, send you to our nutritionist. But they've decided to own this. And I think it's very, very, very fascinating, the results of this. I don't know that this is reproducible in adults because we don't have that data, but I think this will be fascinating for you. And again, you're all gonna get this question from your patients. Can I just go on a diet, specific carbohydrate diet, right? These things are on the CCF website, right? So people can find this stuff, and this is gonna be a great talk, and he'll help us understand, what do we do with these requests for diets? What do we do when they ask us for counseling on diet? So it's my pleasure to introduce Dr. Dale Lee from Children's Hospital. Please welcome Dr. Lee.
All right, I'd like to thank Scott for the kind introduction and also the organizers of this meeting. So yes, I did save Scott's life from that bee sting. I remember distinctly. He was struggling to pull it out himself, so I took it upon myself to save his life. So. All right, guys, real quickly, I'm gonna give an update on diet and inflammatory bowel disease. For the practitioners out here, who has been asked about what to eat from their patient who has inflammatory bowel disease? Okay, so a large proportion raised their hands, and I imagine some of you have also been but didn't want to raise your hands. And if you haven't been asked, I guarantee you it's a question on the minds of your patients. So we're gonna walk through some things, and I have no disclosures. There's definitely limitations to the data on diet and inflammatory bowel disease, so I'll try to be open about the limitations to the data. And I think many adult gastroenterologists and practitioners are extremely data-driven, so the lack of firm data is a little bit intimidating to make recommendations upon for diet. So I'll walk through this, and I hope I can make an argument for why diet is important. So the objectives of my talk, we're gonna discuss the data for exclusive enteral nutritional therapy in Crohn's disease. We'll discuss the data for exclusion diets in inflammatory bowel disease. And then I wanna briefly review the implementation and evaluation of efficacy for dietary therapies. So briefly, the main targets for IBD pathogenesis that we think of, large categories. We think of diet, immune system, gut microbiome. And I will say, by far and away, the emphasis is on the immune system. So what drugs can we use to suppress the overactive immune system? There are also therapies being developed, probiotics, prebiotics, antibiotics, fecal transplantation, and these all focus on modulating the gut microbiome. Importantly, diet has a strong impact on both the immune system functioning as well as the gut microbiome, and this is not yet well defined in terms of what specific dietary interventions can we utilize. So I'm gonna walk through the data we have right now. So a few important points as to why we should focus on diet and why it should be part of the conversation. First of all, our patients are interested and they believe that diet plays a role. Second, there is insufficient efficacy of immunosuppression for all patients. So there's not one immunosuppressive drug that works for all patients, okay? With immunosuppression, there is a risk of infection and cancer, and if you layer on multiple immunosuppressive drugs, that risk can rise. And I'm gonna talk about the data to support the efficacy of dietary therapy. On the left of my screen here is a graphic from a landmark trial, the SONIC trial, and many of you all are aware of this. So they took 500 patients that were naive to immunosuppressive medication, and they were randomized to 3 different arms. So it was azathioprine alone, infliximab monotherapy, or combination therapy of both together. And essentially the takeaway here was, wow, the combination therapy of both was greatly effective. And it shows 56.8% of people were in corticosteroid-free remission at 26 weeks. And if you look at the drug trials, that is a phenomenally great outcome, okay? I want to take a slightly different perspective. What about the greater than 40% of people that were not in this sort of remission endpoint here? So in my opinion, we should also think about what are the other adjunctive or different mechanism therapies that we can utilize either alongside immunosuppressive therapies or independently. So I think that diet can play a role here in that red 40% of people who are not in remission. So I'm going to briefly go over some of the specific dietary approaches. Some of you may be familiar with these, some of them may be new to you. Exclusive enteral nutrition, I'll go into detail, as well as these exclusion diets that have been published and also quite popular in sort of the lay public. So exclusive enteral nutritional therapy, this is the dietary therapy that has the greatest amount of rigorous data, and it's the most well-proven and efficacious. And again, this is utilized primarily in pediatrics, but I'll talk about maybe why the adults don't think about this. It's also known as the defined formula diet. I have a can here because with this approach, you put individuals on a formula-based diet for their nutrition, and they exclude standard foods. So they drink formula only and drink water, but they don't eat other foods. The formula can be either just by mouth, or they may opt to receive it by nasogastric tube feeding. Really importantly, this does not require some fancy IBD formula. This can be any formula that's pretty commonly utilized. It doesn't have to be it can be intact protein, it can be broken down protein, it can be amino acid based. It doesn't really matter what the formula is. It's used for calories as well as for direct therapy. So there's a dichotomy between the pediatric data and the adult data. The adult data suggests if you use this formula-based approach, it is less effective than corticosteroids. That's what the big Cochrane reviews and meta-analyses show. Conversely, the pediatric data show that exclusive enteral nutrition, the formula approach, is as effective as corticosteroids inducing clinical remission. And again, the pediatric data suggests nearly 85% of children enter clinical remission using exclusive enteral nutritional therapy. Down below is a meta-analysis, and there are odds ratios, and there's sort of a summative odds ratio based upon individual studies. If your square is to the left, it suggests that corticosteroids are favorable to exclusive enteral nutrition. If your square is over to the right, it suggests that exclusive enteral nutrition is superior. And as you can see, the big diamond at the bottom, the summation of all the data, suggests that it's fairly equivalent. So it's at an odds ratio of 1. And again, this is pediatric data. 85% efficacy in children for Crohn's disease. The adult data speaks otherwise. So this is a trial that was published out of Italy, and it looked at 37 children with newly diagnosed Crohn's disease, and kids were randomized to one of 2 arms and on this therapy for 10 weeks. They were either on corticosteroids or exclusive enteral nutrition. And the graphic on the left looks at clinical remission. So this is a clinical disease activity index, okay? We look here and we see that the formula approach with EEN was nearly 75% efficacious at the end of 10 weeks, and corticosteroids likewise, a high efficacy near 60%. There is no statistically significant difference in clinical remission. These kids also had follow-up colonoscopies done at the end of 10 weeks. Not a common thing done for pediatric trials, but this is one of the reasons why this trial is good. And looking at mucosal healing, and Dr. Wabe discussed sort of prognostication, and they looked at macroscopic, so what you saw visually. So were there ulcers? Was there a significant visual abnormalities endoscopically? And this showed that, importantly, with the exclusive enteral nutrition, there was far greater mucosal healing endoscopically than with corticosteroids. So this study suggests that mucosal healing was superior with exclusive enteral nutrition compared to corticosteroids. So an important question that people ask is, so do I have to be on 100% formula, or can I eat a little bit? How exclusive do I need to be on formula to make it efficacious? This is a trial done when I was in Philadelphia, and we looked at 90 children who had Crohn's disease. Okay? And it was an 8-week trial, and the outcomes for this trial were clinical disease activity index, the pediatric version, and also fecal calprotectin, which is a surrogate marker of intestinal inflammation. This pediatric Crohn's disease activity index does incorporate some objective markers of inflammation like ESR and albumin. There were 3 arms to this trial, and the arms were partial enteral nutrition, so about 50% of your daily calories from formula, the rest by regular diet. There was the exclusive enteral nutrition, and then an anti-TNF-alpha arm. The first comparison I want to highlight is the 50% formula versus 100% formula. And in the blue bars, we have the outcome of fecal calprotectin less than 250, and in the red is remission as per the clinical disease activity index. If you look at this comparison of EEN and then the partial enteral nutrition, we see that both outcomes are superior for the exclusive enteral nutrition group. So clearly 100% formula is superior to the 50% formula approach. When we compared the anti-TNF-alpha group to the exclusive enteral nutrition formula group, we see that the outcomes here were not statistically significantly different for clinical disease activity remission as well as calprotectin less than 250. Again, we see pretty decent rates of achieving these endpoints. When we took it a step further and looked at a more rigorous outcome of fecal calprotectin less than 50, we see that there was a significant difference. With the anti-TNF group, approximately 25% achieving the calprotectin less than 50, and for the exclusive enteral nutrition group, closer to 5%. So a conclusion here can be that a surrogate marker of mucosal healing was superior at the end of this 8-week trial for anti-TNF versus exclusive enteral nutrition. So an important question, I think a lot of adult providers are in the room, can this formula-based approach be effective for adults? So I'll say adults are different than a parent who is very motivated to keep their kid off of medications. So us adults, we're much less compliant. We don't like if things taste bad, and sometimes we lose motivation. So in studies where adults have tried this formula-based approach, issues of compliance have been a huge confounder. Okay? The other issues with adults medically is that they have a longer disease duration, and oftentimes they have been on prior immunosuppressive medications, so their immune system is somewhat modulated and likely going to respond differently to dietary approaches. All right, so these are 2 trials here. They're published quite a while ago, and they look at clinical remission in adults who are newly diagnosed with Crohn's disease and have the option of getting their formula via a nasogastric tube. Okay? And in these 2 studies, we see that the rate of clinical remission was close to 80% here. And again, I'll be fully transparent. Again, they did not look at mucosal healing, but again, they looked at clinical remission. And if you use exclusive enteral nutrition in treatment-naive adults, and you give the nasogastric tube option to help reduce compliance issues, you can see a better efficacy. So my conclusion here is EEN can potentially be effective in adults, but studies are limited by poor compliance. I'd love to see a study in adults who receive EEN by NG tube for 8 weeks straight, newly diagnosed, and they get follow-up colonoscopies. I think it'd be really interesting. So what about this issue of can you use nutritional therapies in combination with classic immunosuppressive drugs? This is a study done out of Japan. They looked at 102 participants who were induced to clinical remission and also biochemical remission looking at CRP with infliximab. Okay? This is a Kaplan-Meier curve, so everybody starts off at 100% remission. Then over time we see the steps down. Those are people who are falling out of remission. Okay? So they divide people into 2 groups here, and the blue line is folks who are on partial enteral nutrition, so about 50% of their daily calories from formula. And then the red line is the non-partial enteral nutrition group. So they were just kind of eating what they wanted to eat. So recurrence was defined as a CRP that rose above 1.5, or also the need to shorten infliximab dosing intervals. So we see here over time that the group in blue that was receiving 50% calories from formula, they had a lower rate of recurrence of inflammation here. So again, it's interesting. You can use a classic immunosuppressive agent, layer on some nutritional therapy, and perhaps you can decrease the risk of relapse or decrease inflammatory burden. But importantly, if you're going to use the nutritional therapy approach with formula, you need to have a good exit strategy in mind. Because this is only used in general for somewhere between 4 to 10 weeks to induce remission, you will need to transition to some form of maintenance therapy. So the options include immunosuppressive drug therapies, Some people will opt to continue exclusive enteral nutritional therapy longer, and some people want to transition to a whole food-based exclusion diet. I'm going to go over some of those now. So some diets that you may have heard about, specific carbohydrate diet is quite well known in our patient population. The Crohn's disease exclusion diet is a diet that's been popularized by Ari Levine's group out of Israel. It's receiving quite a bit of press recently, published in Gastro. Semi-vegetarian diets have been studied in Japan. The CD treat diet is interesting. I'll go over some of the data. And quite a few people talk about generic anti-inflammatory diets. If you try to look at a common thread between all these diets, it's really hard to pick out, but some common threads are avoidance of bread, gluten, and also processed foods. And again, that includes food additives. There's great variance in can you have dairy, can you have sugar, is animal fat allowed or not? So the specific carbohydrate diet. So this is a restriction diet, and it involves the removal of all grains from your diet. Okay? So this is wheat, corn, oats, all grains, rice. You remove refined sugars. You really minimize cow's milk products. You can have yogurt that's been fermented for 24 hours and certain hard cheeses. You also pull out the very broad category of processed foods. So the thought behind the mechanism here is that you minimize ingestion of substrates that will promote dysbiosis and inflammation in the gut. There is a very large popular following out in the lay community, and there's tons of anecdotal evidence that's quite plentiful if you look online. We also have some more rigorous data that we're working on, and I'll go over that. So this is a study done by my colleague Dave Suskind, and he collaborated with a group in Atlanta. And they looked at prospectively specific carbohydrate diet in 12 kids over the course of 12 weeks. Again, they looked at objective changes to inflammatory markers, and we see that over the 12-week interval, there was a drop in the CRP. When you looked at the calprotectin, the Seattle group, which had 9 patients, had a significant decrease in mean CRP. The Atlanta group with 3 patients had a rise in CRP, largely driven by one individual that had a greater than 1,000 increase in the calprotectin. But again, looking at objective markers of inflammation, important here. So here's a quick summary of the data for specific carbohydrate diet. And again, I'll be very transparent. It's not particularly rigorous. If you look at the study design, it's usually sort of a case series. We did a patient survey with a large number of patients. So many of these are sort of limited in their study design, okay? But in general, people see improvement in labs, growth parameters. Mucosal healing was also seen in the study on the very bottom here. They did capsule endoscopy there. There are a couple new multi-center trials which are ongoing, which I think will really change the lay of the land for specific carbohydrate diet. One study is going on, it's called the PRODUCE study, and they're enrolling individuals, and you're going either on a strict specific carbohydrate diet and then transitioning over to a more modified liberal form, and you flip-flop back and forth after 8 weeks on each. So you're able to use yourself as a control. A study that's happening in the adult world is called the DINE-CD study, and it's a randomized trial where you get either the specific carbohydrate diet or the Mediterranean diet. The food is shipped to your home, 3 meals and 2 snacks, and it's over a 6-week period of time. And the goal is to see what happens to your objective markers of inflammation and also your disease activity indices. I mentioned the Crohn's disease exclusion diet. So this was a prospective study done in Israel and in Europe, actually. They looked at 37 children and young adults, and they looked at a diet that they described here, excluding gluten, dairy, animal fat, processed meat, emulsifiers, canned goods, and foods with an expiration date. And they also gave 50% of your calories via formula. Okay? And we see here that there was a decline in the CRP, so objective marker of inflammation, and also improvement in this disease activity index. This is a very recent publication that I think is fascinating. So what they've done is they've taken this idea that exclusive enteral nutrition formulas can be beneficial at inducing remission. And what they've done is they've looked at modulin, which is one formula that's commonly used in Europe. They've tried to match the nutrient contents with a whole food-based diet. So they hired a catering company, and they sent people this food, and they looked to see, can they get the same changes to the microbiome and the stool metabolites with both of these different approaches, modulin formula, and then the foods used to emulate the nutrients in modulin formula. The results from this study show that 28 healthy adults had very similar effects on their microbiome and stool metabolome using both different approaches, whole food and the formula. They tried to treat 5 children with active Crohn's disease with this whole food-based approach, and we see here on this graphic there was a decline of calprotectin from a mean of about 2,500 down to 4 to 8 weeks, about 1,000. Okay, so there was a change in the objective marker of surrogate inflammation, of gut inflammation. Importantly, though, we see that the calprotectin stayed quite elevated at 1,000, so there was a decline, but this did not really drive the inflammation all the way down. So you may have the question in mind, so which exclusion diet should I consider using if my patients come and talk to me? So I would say exclusion diets, they've clearly demonstrated some efficacy, and there are further trials ongoing to evaluate specifically which dietary components are important. We may learn that specific carbohydrate diet works for certain people, but maybe the Mediterranean diet can be significantly beneficial to other folks, helping to improve inflammation in some sense. The drawbacks to dietary therapies include the potential impact on the quality of life and also the potential for nutrient deficiencies if not appropriately supported by the medical team. So practical implementation. So there needs to be partnership between the GI doctor and the APP group, the dietitian and the patient family, okay? You need to have a skilled dietitian as part of this in guiding either the formula-based approach, calculating caloric needs, and also if you're on an exclusion diet, you really need to be monitored because some people will lose weight and have, they're removing large food groups from their diets, so they could become nutrient deficient. If you're going to use exclusive enteral nutrition for Crohn's disease, again, it's not for UC, you want to ensure folks don't have abscesses or strictures, which could really be problematic. And importantly, so if somebody wants to do dietary therapy, they have to be motivated to try this. You can't force this on somebody. It's significantly impactful to your quality of life, okay? And then finally, it's important to have a finite time frame. If you're going to try a dietary therapy approach, you need to say, by this point in time, we're going to assess for efficacy. If not showing efficacy or improvement, we need to move on to the next therapy. So briefly, monitoring response. So in my practice, we encourage follow-up at 3 to 4 weeks from initiation, following up to see how individuals are doing, monitoring weight, having a dietitian meet with them. Thereafter, we recommend at least every 3-month visits. The parameters that we follow are overall well-being, symptoms, weight changes, and then objective markers of inflammation, including labs, calprotectin, and follow-up endoscopy to evaluate for mucosal healing. So briefly, in summary, present immunosuppressive drug therapy is not adequate to induce and maintain remission for all patients, okay? So dietary therapy may have a role, and it has a different mechanism of action. Second, EEN, effective therapy for pediatric Crohn's disease. I think the story in adults to be determined. Restriction diets involving regular foods have shown promise, but more data is needed. And finally, we like to think dietary therapy can be used either as monotherapy, carefully monitored, or maybe used very efficiently as concomitant therapy alongside immunosuppressive drugs as well. Thanks, guys.
Thank you, Dale.